My name's David Agarwal. I'm an interventional radiologist at the IU School of Medicine at IU Health, and I've got kind of a niche role in the management of neuroendocrine tumors. When we talk about interventional approaches, we're talking about things that are minimally invasive, but still relatively high bang for your buck. I'm looking at ways of doing things without surgery and hopefully with low toxicity. So what I'd like to talk about this morning is a couple of those approaches and kind of walk through what we do in our day. So the disclosures, don't really have any. I'm open to suggestions. I like Mountain Dew and chocolate. I'm going to start with a case report. And actually, I can't see that, so I'm going to walk around. Yeah, same kind of thing. So I'm going to stand over here. For a guy in his 60s comes in, has ulcerative colitis, a disease of the intestines. Has been treated surgically. He had some bleeding that led to a CT scan. That shows a small bowel tumor and at least one liver lesion, and a biopsy showed carcinoid. So what happens to this guy? He gets one surgical procedure to remove the small bowel tumor. They resect the biopsied liver metastasis, and a month later he has a second surgery. This one's pretty extensive. 2 left liver resections removing 10 liver metastases, 13 right liver wedge resections removing 20 metastases. We take out a chunk of the middle of his liver and his gallbladder. He did great, but 6 years later, he's got scans that show multiple metastases, again involving all segments of his liver. The largest is over 5 centimeters on the left side and over 3 centimeters on the right side. 7 years later, progression of disease, elevated serotonin levels, but he's asymptomatic, taking a somatostatin analog. Great performance status. Does this sound familiar to anybody? Right? This is how people come into the system, and we kind of do what we get. So on my side, I'm a liver guy. I get to treat folks that have disease. If we're talking about the guests that are uninvited, these are the guests that are hanging out in the guest room in the liver, right? I want those guests to leave, and I can do that by targeting just the liver. I'm kind of ignoring the rest of the house, but I'm targeting the liver. So when we're looking at these, we've got lesions that are inside the liver that look kind of weird. They light up on scans. And we follow these lesions throughout the right side. This is predominantly the right side. And our goal is to make these lesions go away. He's had progression of disease. He's asymptomatic on somatostatin, but his lesions are getting bigger, and they're growing in number and size. So we're going to try to target something to treat him. He was treated back in 2007, back before this 2008 article came out that said radioembolization works. So I'll talk about radioembolization a little bit later, but in essence, we put radioactive particles into the liver. They flow to where these tumors are. The radiation sits there, hangs out for a couple months, and kills things. So when we do these procedures, we take an artery, or we put a catheter into that artery, and we will get it into the liver. This is the right side of the liver, and these blushes are tumor stains. And with my niche techniques, we're going to try to take these things out. We do a test dose of a radiation. We see on a scan in nuclear medicine that the liver takes up tumors, and our goal is to make them go away. We can do some fancy spreadsheet calculations to figure out what the dose is going to be, and then we come back another day, usually about 2 weeks later. For radioembolization, we go back into that same artery, and we put the radioactive particles in here, and they flow preferentially to these tumors and make the tumors go away. So on follow-up at 3 months, we see lesions that looked like this before, either just kind of going away or becoming dead spots in the liver, and we kind of follow them over time. And at 14 months, same kind of appearance. We get stability, so stable disease or regression of disease. So he's a good result. That was nearly 2 years later. 10 years later, he was still going. But we kind of follow folks in our clinic and see if there's something that we can do to help as an adjunct to medical oncology or surgical oncology. So what do we do in interventional radiology? We do arterial procedures and ablations. So basically sticking needles in people, either into an artery or into the organ, and doing something that kills the thing at the tip of the needle. With respect to artery work, we can put in chemotherapy, and we'll talk more about embolization and chemoembolization, drug-eluting beads and radioembolization. There are some other kind of procedures that we can do as well, but not quite as fancy. We're going to focus on these 4 for arteries and these 2 for ablations. Ablations are kind of like biopsies. Also within the radiology world, we will put a needle into something, and at the tip of the needle take a sample of whatever's there and send that off to our pathology friends, and they'll tell us what's going on. We're looking for grade, type, whatever we have. If we can get a needle for a biopsy to that location, we can get a needle for therapy to that location. Okay, so we can use radiofrequency ablation, microwave ablation. Another interesting one that I'm not going to talk about because we don't use it is irreversible electroporation. So with respect to artery work, when we put things into the arteries, we've got a couple goals. We want to put, let me go backwards a second there. We put in particles, or particles plus chemotherapy and a type of an oil. And then as our techniques evolved a little bit, the vocabulary evolved a little bit. We stopped calling them particles, we started calling them microspheres, same thing. But we can load them with chemotherapy or with radiation. And the goal here with these arteries is to block the flow of blood and stop the tumor from getting artery blood so it dies off. So we get tumor ischemia and tumor necrosis. So the particles look like this. They can be powders. They can be rounded spheres or contoured shaped spheres. We used to put in particles that had these jagged edges, and then the machinery got better to make these rounded particles. They come in different sizes. Each color is a different size. And you can kind of see them floating inside a syringe or inside a vial. And this is a vial of radioactive particles. So the theory behind this is that we get to go into an artery and stop the artery's blood flow. It's like floating little pieces of cork into an artery and stopping that artery so no more blood can go into it. The artery that we choose is the one that goes to one side of the liver or the other. So if you look at the red lines, we can follow these artery branches going into each portion of the liver. But we also see adjacent to that small red line a big blue one. That is a portal vein. The portal vein brings about 80% of blood into a person's liver. So if only 20% of the blood comes from the artery, even if we kill the entire artery, the portal vein will still be there to support the liver, and people can live without their arteries. We're going to take advantage of that technique, though, to say if we put something into the artery that can flow with the artery to a tumor, we can kill whatever's at the end of that artery. So we kind of look at this balance of vein blood and artery blood and say we can do things to the artery and with success, treat the tumors. What's nice is tumors preferentially get most of their blood, about 80 to 90% of the blood from the artery. The normal liver gets most of its blood from the vein. So if we hurt the artery, we hurt the tumor more. If we hurt the vein, and we do that on purpose sometimes, we hurt the liver more. But our techniques for tumor control are going to be based on artery therapy. So we have these small arteries that go in, and we can choose which artery we want to go to. I've got a couple technical slides that I'm kind of gloss over. This is one that's very wordy. We can just kind of work on the theory as opposed to all the words. But liver metastases have to get pretty big before they get arteries. And at about a 3 millimeter size, they start to get more arteries than the tissue around them. The normal liver still has the normal arteries coming to them. But as these tumors enlarge, they get more blood vessels coming to them, bringing more sugar, bringing more oxygen, bringing more things to the tumors need. What we want to do is stop that process. So once these metastases get a little bit larger, we can start to see them on scans. And when we start to see them on scans, we can start to treat them. Our scans are a bit interesting. We sometimes miss the fact that these tumors actually have a very strong artery supply when we do our scans. If you look at a regular CT scan, sometimes these tumors in the liver, these metastases, look dark. And the darkness is an area that does not have the contrast that we give folks into their IVs, that it flows through the arteries and gets into the liver. So we think by looking at this scan that there's more contrast and therefore more blood flow to these areas of the liver and not to these tumors. But if we were to put a catheter into the artery itself and then put that patient into a CT scan, we can see that these tumors just light up. And the rest of the liver, also getting artery blood, does not get very bright. So we know that almost always we will find a strong amount of blood flow going to tumors and much more blood flow than we see going to normal liver. And that's the foundation of our interventional therapies in the liver when we go through the arteries. So here's what it looks like. We put a catheter in, inject iodine contrast. We see these blushes, which represent tumors. And then we put something in to stop up that flow of blood. And this is a chemoembolization where we put in particles, some oil, and some chemotherapy. And as we inject blood at the end of that, we see all these arteries are kind of plugged up. We don't see that dark blush anymore. So that tumor is now deprived of its artery blood. Instead, when we inject contrast at this level, we see it kind of backing up and going to the other areas of the liver. So the other areas of the liver still get good blood flow, but the area that we're targeting no longer has that artery blood flow. So we can do this with particles to stop up the flow of blood. We can do this with chemotherapy and particles, which stops up the flow of blood and delivers something very toxic into the liver. We can do this with radiation. It's a little bit of a different technique. And we can do this with particles that are loaded with chemotherapy. So all these things can be put into the arteries. They all, in essence, do the same thing. When we look at trials, and we'll talk about them in a little bit, they all work about the same. So we'll have to talk about why we choose one embolic technique over another one. So we know we're taking the artery blood away. When we do embolization that we call bland embolization or chemoembolization, we totally plug up the flow of blood to these tumors. When we use radioembolization and drug-eluting bead embolization, we don't plug things up as much. We use fewer particles, they're smaller, and they're carrying something very toxic into each tumor. But the blood flow is not knocked down as much, so people tend to do better. They don't take the artery hit that they would take if we had to completely block the flow of blood. And I think that's the foundation of why some of our newer techniques, like radioembolization and drug-eluting bead chemoembolization, are better tolerated than the older techniques that we used to use. We're still keeping some artery blood flow going through. So here's what it looks like on a CT scan. A bright tumor kind of becomes a scar over here. There's a little bit of oil still sitting there, and the edge of this liver is kind of curved in where that tumor used to be, and it died off, and the liver just kind of scarred inward, and the liver kind of retracted at that level. So these are small devices. When we're talking about the size of particles that we use for radioactivity, they're smaller than the size of a hair. And there are a couple different brands, of course, of everything that come on through. One is Therasphere and one is Ceraspheres. Radiation, if you put it in through the arteries, let's start with the other side. The other side of this is when you do external beam radiation, we aim radiation in from the outside of the patient into the patient. And that puts radiation into a target lesion. When we do it from the arteries, we put radiation into the arteries that are surrounding the tumor, and the radiation sits there and treats the patient from the inside out. So I think we have a little bit less collateral damage of the normal liver tissue around where the tumor is. So, comes down to goals. We're trying to have a survival benefit. We're trying to either reduce the amount of tumor in the liver to keep things to the point where they can either be surgically resected, treated with ablations, or maybe even go to transplant. So we're helping surgical management or medical management, or we're trying to do palliative therapy. And that's actually a very beneficial part of what I do. When we have liver metastases that are sometimes symptomatic, in that 10% of the group that secrete hormones, we can knock down those liver metastases so they stop secreting that hormone. And if the bulk of the hormone is coming from the liver, that symptom control is very beneficial. So why does hormone come from these liver metastases? If you think about where these tumors are, oftentimes in the gut, and the gut secretes hormone, that gut tumor secretes hormone, the liver is actually going to break down that hormone. It's processing it. If, however, a metastasis starts in the liver, and then releases that hormone. When it dumps that hormone into the vein, it flies out of the liver without being processed. So you get more symptoms from those metastases that are in the liver. So we can treat by knocking down hormone symptoms, and we can also treat metastases in the liver that are getting larger, irritating the outside edge of the liver where all the nerve endings are. And when you start to irritate that, you get pain. So I think the biggest benefit of our therapy, in conjunction with somatostatin analogs and surgical resection, is that we can offer palliation of pain and symptom control. So where do we start? We've talked about biopsies and imaging, so you'll come to radiology for that. Tumor markers, you'll go to the lab. We'll get nuclear imaging of some kind to determine the extent of disease. And if it's primarily in the liver, that's where interventional radiology has a role. If it's outside the liver, but liver dominant, we still have a role. But if it's throughout the entire body, we need something that treats the entire body, some systemic therapy. And there we become more of a secondary player. We don't oftentimes remove tumors in the liver if there are tumors elsewhere that need to be treated as well. We're looking for a survival benefit, not just treating a tumor because we can. Okay, so for our multidisciplinary evaluation, we've got our primary care teams, our medical, surgical, and radiation oncology teams, our diagnostic, nuclear, and interventional radiology teams. We're all talking about patients and trying to figure out what we can do. When we evaluate a patient from the interventional radiology side, we're looking just as the medical oncologists are for inclusion criteria and exclusion criteria. We want to make sure our therapies are going to be safe. So we're looking at the liver function, we're looking at how a person is doing day to day, what's their performance status, how functional are they. Our side effects can be pretty severe. Usually these procedures are pretty well tolerated, but there are things that we do have to watch out for. When we do block the flow of blood to any organ, we will cause an effect. And what we call the effect in the liver is something called a post-embolization syndrome. If we deprive the liver of a certain amount of arterial blood, a person's going to hurt. They'll have pain, nausea, fever, and we'll check their white blood cell count. It'll be high as well. You know, if you think about a person that loses the artery blood to their heart muscle, they get a heart attack. You get an elephant sitting on your chest. It's not quite so bad when we do an embolization in the liver. The pain is usually pretty bad over the first couple hours, decreases overnight, and we can usually shift people to oral medications as opposed to IV medications by the next day. So most of our folks stay in the hospital one day and then they can go home. The major complications, the biggest one is an abscess risk, and you'll see down below that if we have bacteria that are in the bile ducts, so if a person has a connection made between their bile duct and their intestine, we have to watch to see if bacteria come up, and if they get into the liver, when we block the flow of artery blood, their abscess risk goes up. We can treat that with antibiotics beforehand to decrease that risk, but it's something that we have to watch for. Surgical connections, ERCP are things that we have to look at. 30-day mortality is not really, it does happen. People die after these procedures, but it's usually not because of the procedure itself, but the extent of disease that we're treating or progression of that disease. So if we are treating late in the game, we're going to be taking a little bit more risk, and those are the folks that are a little bit more tenuous and late stage. So when we look at neuroendocrine tumors, we can get responses. The responses tend to be better in the well-differentiated carcinoid tumors than in the islet cell tumors, better survival overall. Carcinoid tends to be a better actor when it comes to neuroendocrine tumors compared to others. We see that when we look at these different types of tumor types, that if we use bland embolization or chemoembolization, you may have a little bit of you'll get a benefit, but sometimes the benefit is hard to tease out. So what I highlighted in this slide, and this is that same slide from the one before, we have patients who can have their primary tumor resected, and we see a survival benefit with that. Those are, to start with, perhaps our healthier patients. They can tolerate more therapy, more aggressive surgical resection, ablations, different things. So in that group, if they have a resected primary, they tend to do, if they can get their tumor resected, they tend to do better overall, and they survive longer. Folks that may not tolerate a surgical resection, they may be the sicker group of people. They may get what was considered a lesser therapy, a less dangerous therapy, something like a bland embolization without the chemotherapy. And they may not have as much of a response, they may not survive as much. It's hard to kind of tease out this because the statistics don't really give us direction one way or the other as to what we should be doing. You can look at almost any of these medical studies and say, well, that works, but what should we do next? We did a study here at IU that was part of a multidisciplinary group. We provided about a third of patients for a trial that looked at either chemoembolization or bland embolization. The groups are pretty much the same. About 50 to 60% of them were carcinoids, 50 to 60% of them were small bowel. Most of them were both sides of the liver. There was a little bit more of a bias towards more treatments with the chemoembolization group, and they were also the healthier group that had a little bit more tumor resections. The less healthy group got seemingly a lesser therapy or more chemotherapy-based treatment as opposed to surgical management. And when you look at these guys, and I think I lost my slide forward device, my clicker. Thank you. If you can see here as well, in the different institutions, whether it's Milwaukee or Madison or us, Milwaukee almost always does a chemoembolization. We almost always do a bland embolization for these neuroendocrine tumors. Milwaukee does a lot more aggressive resections. we do more octreotide and perhaps more chemotherapy. Could I get the next slide, please? I'll use this. When in our study, we found very similar morbidity, similar mortality, good symptom improvement across both techniques, but no real survival benefit. The thing that, again, predicts survival benefit is if you can take the tumor out to begin with. So if you're a good enough patient that you can have your tumor resected, you'll probably do better long term. So a 2013 study, our study was about 10 years ago, this is 2013, found when you look at 24 studies, wide range of responses, depending on the histology, the type of treatment provided, whether it was provided early or late in the stage of diagnosis, if somatostatin analogs were given or chemotherapy was given. You couldn't really tease out trends because the statistics don't really match up. We see a benefit, but we can't say which therapy is more beneficial for an entire group of patients. We can kind of say for an individual patient this might be better, but that becomes more of a subjective choice. So if we at IU tend to do more bland embolizations, you'll probably get a bland embolization. If you go to Milwaukee, you'll probably get a chemoembolization. You kind of look at it that way. You get a wide range of responses, but across all of the studies, if you take out one outlier of about like a 60%, about 75 to 100% of people get better symptom control. And I think that's where we have our greatest benefit with respect to treatment of liver metastases. This is a slide for radioembolization. So all these therapies will work. They all will reduce hormone levels. They all palliate symptoms. They all reduce tumor burden. We can't show superiority of one type of treatment over another, so it becomes very individualized how we approach people. So the way we'll take a look at this is to try to understand what a patient's starting with and where they want to go. It's going to be very individualized, and it's going to be very operator dependent. All of these therapies will provide you with about a 45% size reduction at 3 months. Right? If they're very hypervascular, you can get into about the 70% size reduction at about 3 months. So when we look at our response rates, they're not too bad at the level of the liver. So realize that we're only trying to control liver-only or liver-dominant disease, and if we can get a 45 to a 70% response rate, I think we're doing pretty well. If we can control symptoms, I think we're doing pretty well. And yeah, lacking statistical power, I'm not sure we can say exactly what we should do for every patient coming through. So we have old assumptions that kind of said that chemotherapy is a little bit more toxic, but perhaps because it lasts longer with chemoembolizations, it's a better technique to do than a bland embolization. I think sometimes we have to revisit these old assumptions. I'm not sure that chemoembolization is going to provide a greater survival benefit overall. It may give you a more durable response, but if you can repeat bland embolization more frequently, perhaps that might be another way to go. So we tend to look, at IU at least, we look at bland embolization as one of our frontline treatments, but also radioembolization as one of our frontline treatments for neuroendocrine disease metastatic to liver. So just a couple of pictures. In the second category of what we do, just to finish up, I've got about 6 slides on ablations, and ablations are pretty straightforward. It's based on anatomy. You, on the heat side, with microwave and radiofrequency ablation, we put a probe in, put it into a tumor, and we flip a wall switch. When we flip that wall switch, it delivers electricity and generates heat at the tip of the needle. And if this is the tumor, we try to generate a burn zone that is much larger than the tumor, so we can take out not just the tumor, but what we call a margin of healthy tissue around it, so that we can ensure with a greater likelihood of success that we're not going to have recurrent disease at that level. The heat is going to go beyond that margin, and it's going to go a little bit farther, so there may be some more collateral damage to liver adjacent to it, but that's not going to be deadly heat. We're focusing the deadly concentrated heat at the level of the tumor. Different types of needles can be put in. They're very easy to use with ultrasound guidance and actually CT guidance as well. We want to get this kind of cooked liver appearance. You can see the needle probe going in, and this is a dead liver section at the edge of this liver. So just like a biopsy, we put a needle in. We can deploy tines at the tip of this needle to kind of capture the tumor, and then we flip on the heat. This is an example of a solitary islet cell. Had grown in size over 2 years from 8 millimeters to 1.5 centimeters, so 8 millimeters to 15 millimeters. It was the only thing that she had in her body, but she couldn't live with it. She just wanted it to go away. So chemotherapy, to treat a small little lesion, that's a lot of risk, a lot of side effect. Surgical resection, clearly an option, right? This is a cherry lesion to take out of the body, but with a little bit more risk. What we can do is put a needle through that and get the needle to turn heat on at this level and make that lesion, which looks like this is the immediate look directly after the needle's removed, and a couple months later we see a scar and that tumor is gone without opening a patient up. So we have options that perhaps are a little bit less invasive. Another example of a neuroendocrine met to a liver, this is a microwave probe coming into that edge, and you can kind of get that burn segment over there. So ablations have a role when tumors are small in size and few in number. We don't see them very often like that. We oftentimes have more multifocal, both sides of the liver disease, and an ablative technique in that case may not be very beneficial. This is an example of a cryoablation. It's actually not a liver cryoablation, but of a kidney tumor that was coming up to the liver. And it's just neat as a picture to see how you can see the ice forming at the tip of a cryoablation needle to encompass the mass. And basically what that technique does, it's like water in an ice cube tray in your freezer. The water expands, and as the water expands, it can kill things. How does it do that? Cells have water. As a cell expands and breaks open with freezing, the membrane of the cell ruptures, and it can't get put back together again. It's not Humpty Dumpty. The last thing, IRE, irreversible electroporation, works on a different concept than heat, but it's also very helpful. It kind of breaks up those cell membranes as well, so that's a technique that I think has some promise on the side of ablation. We don't do a lot of ablations for neuroendocrine tumors, just because they're usually multifocal. They're usually larger than 2 centimeters in size. We can ablate things up to about 5 centimeters, but you want that margin to go all the way around to ensure that you have a greater likelihood of success treating things. Where we do use ablations for neuroendocrine tumors is when, after a long, durable response to treatment, one little lesion pops up somewhere. All right, so if you see one new lesion 5 years out from therapy, and that's all you've got in your body, I think ablation might be a perfect thing for you. So we want these guests to leave. We can throw things through the arteries. We can throw things in with needles, but we can have fun with them along the way. Our goal is survival, quality of life. We're looking at this from a multidisciplinary approach, a multimodality approach. We're looking forward to the evolving therapies that are coming through. Quite honestly, I'm hoping I'm put out of business. I have a feeling that if we're going to replace liver-directed therapies with something systemic level, that'll be fantastic. If we can do targeted receptor therapy to hit all these little lesions, not just in the liver but elsewhere, that'll be a huge benefit. For the short term, however, because about 50%, more than 50% of people who present with neuroendocrine tumors are starting at the time of diagnosis with liver metastases and not metastases elsewhere. Then there may still be a role for liver-directed therapies as we're going through for size and number control, but also for symptom control. All right, so we're trying to figure out where we fit in that niche to make things work. That's my talk.